Thank you, guys. Hope you're having a good evening, and welcome to tonight's small session on thoracic injuries. Today, we're going to be talking about the treatment and how to diagnose and actually treat thoracic injuries in ACM. This is going to be a more basic course. We're not going to go in depth into the actual mechanics, code, and stuff. It's not just going to be like basic treatment, right? Just a small little disclaimer. I think you guys are all aware that this is not IRL medical advice. I'm not really going to be discussing with you IRL medicine as well. There's going to be different SOPs for every country, EMS, military, etc. That is not the point for today. I'm going to explain a little bit of actual IRL medicine, but that's just going to be very short and very simplified. As I've said, questions, you guys can just ask them away. I'll read through them at the end and try to answer them. So, let's start with the definition. Pneumothorax itself, that refers to a state when there's air in the pleural cavity. I'm going to talk about the pleural cavity in a second. Hemothorax, that is basically just like pneumothorax, but instead of being air, it's going to be blood. And both are basically created, or the issue being that there's a injury, most likely penetrating, that either allows air to get into the pleural space, so like if there's an injury to the chest, or for example, knife hitting blood vessels, and from then on blood leaks out of the vessels into the pleural space. Both of those can deteriorate into their tension versions. I'm talking about ACM here. Deterioration rate depends on the settings that you have. So you have to watch that out depending on what service settings you have. Both will, if not treated, will lead to their tension versions. And they have a slight difference in treatment. But you have to keep in mind that tension pneumothorax especially is going to cause cardiac arrest. And during cardiac arrest and management, you will have to keep in mind about the reversible causes. Now about that pleural cavity or pleural space, I just talked about the lung effectively glides along the inner side of your chest, so to speak. So if we have an injury here, I don't know if you see my cursor, but if we have an injury here, for example, if there's air or fluid getting in this picture, it's going to be fluids. This is going to severely hinder the lung actually from being able to slide along the inner side, and it cannot really expand or inflate and deflate properly. This will obviously result in a decrease of SpO2, especially in ACM, but more on that in a second. One of those treatments would be, for example, putting a needle and draining that fluid out, but as I said, we'll talk about that in a second. The causes basically in ACM, now we're just going to, from this point on, be talking strictly about ACM, or ACE rather, is that when there's being damage done to the chest, and then there's going to be a wound type from that, and velocity, punction, and avulsions will, with that size going minimum or up, are going to be causing those thoracic injuries. After that, there's going to be a few dice rolls, whether or not it's going to be the left or right lung, or for example, if it's going to be a pneumothorax or hemothorax. And from then point on, it's going to start deteriorating without treatment, right? You always have to think about that, especially when you're not immediately at the point of injury. You might go to or present at a patient that already has developed maybe a severe pneumothorax. Your best diagnostic tools basically is going to be that inspect chest action that you unfortunately can only do on unconscious patients. in combination, that's very important, in combination with the inspect chest with stethoscope action. So what that means basically is that you're going to auscultate. I'm going to show you a picture in a second. And you're going to use that information you get from the inspect chest in combination for your further treatment. Now, obviously, for example, other vital signs you can look at, but those are not definitive. That's not going to be like your main reason you're going to, for example, perform an NCD. Now about the auscultation, we have this beautiful picture on the ACM wiki. You can see here, I want you to focus on those blue points that are for auscultation. But actually what's very important is that you don't really do every single point, but I want you to pick 2 points. If you see my cursor here, you can, for example, take the one on the chest here, and I want you to do a side-by-side comparison. So place the bevel on the right side, listen to the inhale and exhale, and the same on the other side. Because you only need that side-by-side comparison right now, at least. And what you're going to hear basically are diminished breath sounds. It doesn't really matter if it's left or right. Any sort of diminished breath sounds will be the sign for you that there's a thoracic injury going on. If there's no sound at all, that might be, for example, caused by cardiac arrest or basically the patient not breathing. If you don't have anybody who's breathing, you're not going to be moving air around, therefore you won't be able to auscultate properly. Now, about the sort of deterioration or development of the pneumothorax and its tension version. Early on, directly after that injury is basically added to that patient, from that, for example, let's say medium avulsion, you're going to immediately see an uneven chest, whether or not he's breathing or not. So you see in the messages here on the feedback in the medical menu that it's going to either say that he has an uneven chest rise and fall or actually no chest movement. On the top right, maybe as you know already, you're going to also have that same message again. That lower icon you see on the timeline itself, that's what I basically refer to as the auscultation. We're going to have diminished breath sounds. For example, in this graphic right side, it can also be on the left side as well. Now, with it deteriorating, so for example, you not putting a chest seal on, it will later on get into that tension pneumothorax, and it will be shown. Just keep in mind that tracheal deviation that you will see here is going to be a late sign of tension pneumothorax itself. This means that tension pneumo has already developed, and he's actually in it for 300 seconds already. Keep that in mind. So you're going to see that tracheal deviation when inspecting the chest, or when you click the head in the medical menu and the medical overview, you're going to see it actually written down there that there's a noticeable tracheal deviation. Now, about the hemothorax. As you can see sort of in the timeline, there's no immediate way of finding out if your patient has a hemothorax. The earliest sign you will be able to tell is during auscultation, or with auscultation, you're going to have diminished breath sounds. Right after that, a couple of seconds, you're going to have that extensive bruising upper chest in that medical menu, or when you are inspecting the chest, that feedback as well. On top of that, you're going to have uneven chest sides in combination. So you're going to have uneven plus that extensive bruising, right? And as you can see in the different colors on that timeline, between the purple from the one picture in the middle and the one on the right, the worse it is, the more bleeding there is, the more purple it becomes. Just keep in mind your patient can have a hemothorax, but because it hasn't crossed that 500 milliliter threshold, it's not going to be shown in your medical menu. So just because you don't see that extensive bruising doesn't necessarily mean that he's not in hemothorax, right? Just keep that in mind. And another very important thing that you have to keep in mind, maybe you don't know that already, that has been sort of recently changed, is that normal extensive bruising on the chest basically means that the lung is unaffected. This is a separate internal bleeding that does not affect the lungs. On top of that, if you have both in combination, so extensive bruising lower and upper chest, this means that you have both bleeding into the lungs and regular bleeding in your chest. This doesn't really change a lot of your ways you're treating it, but this just gives you a feedback on how severe the internal bleeding is, right? So about the more indirect signs, this is if you have the option to it or you're not really sure, you can use that on top. Now, I've made like 2 small sections. One with the respiration section, obviously cyanosis or the reduced SpO2 is going to be one very serious sign. You're going to see that in the pulse oximeter. Breathing rate is obviously going to go up with the body basically trying to compensate for that loss of SpO2. It's either going to be rapid and shallow or rapid, depending on its severity. And you're also going to have reduced EtCO2 from that bad gas exchange, basically. In that circulation section, you're going to have tachycardia, so a very fast beating heart, and you're going to have increased capillary refill time, or basically decreased MAP or decreased blood pressure. Most likely this is in hemothorax patients. What you sometimes can see is actually patients going from lost some blood to going to lost a lot of blood, doing that jump even though they have no external injuries or external wounds. This is your sign that this could be a hemothorax. This can sometimes happen, but the thing is, using blood loss to estimate if it's a hemothorax or not is very bad, because generally those patients will have additional wounds where they could have bled through basically or lost blood through, and this is why you can't really use it as a single sign on top of it. Another a little bit miscellaneous thing that didn't really fit into those 2 sections is those options to perform the treatment for the chest injuries. They only appear after damage has been done to the chest. The other one, that small heart there, basically signalizes that your patient is going to hear or have a sound with the heart beating. That beating heart sound basically only comes when your heart is either beating abnormally fast or abnormally slow. I'm going to have another sign for your patients in a second there as well. And another thing, especially for cardiac arrest or during CPR, you're going to have your patients that are going to be presenting impulseless electrical activity and also an average EtCO2 of less than 10, because they're basically H&T locked and that gas exchange isn't properly working. Now about that last sign I was talking about, you see around the edges where the your vision gets sort of smaller. In more severe cases, it's going to look like this. This is basically just a sign that your SpO2 is going down. The worse the SpO2, the less of your screen you're going to see. You can always ask your patients, hey, is your screen going dark or stuff like that. It is actually very helpful because you don't necessarily have to be on your patient. You can, for example, treat others while you're maybe asking him and maybe also directing him to put a chest seal on himself, buying you a little bit more time for those other critical casualties. Now, the general flow of treatment, there's basically 3 steps, which you cannot always apply, but as like a general recommendation for me is the first one, that you perform that initial action that you want to or have to do for that thoracic injury, reassess and then repeat. For example, if you have a pneumothorax, you do your action, it doesn't help, you can always, for example, escalate if it's a bug or something else, you misdiagnosed it, and you can go up to a thoracostomy, but more on that in a second. So the treatment, I'll start off with the pneumothorax. Pretty easy, it just requires a chest seal. After that, you're done. Then a little bit harder, the tension pneumothorax. I want you to apply that chest seal. Then reassess, look if, for example, in the unconscious patients, the chest is uneven, and or if the auscultation, or if you find in the auscultation that there's still diminished breath sounds, you will have to perform that NCD. But keep in mind, uneven chest sites without extensive bruising, right? As we've sort of talked about a second ago. One very important thing is that the improper use of NCDs do cause a normal pneumothorax, and you will have to treat that as well. So just always keep that in the back of your mind when thinking about using an NCD. And now to the more elaborate treatment, and that is going to be for hemothorax and tension hemothorax. It's going to be the same treatment or same flow of treatment. Again, you see with that chest seal, if you are unsure generally and you don't want to analyze every single wound on that chest, you can also just slap on a chest seal whenever the option appears. Obviously, this will be a little bit of more of a drain on your resources, but you are going to be on that safer side. Now, we have that issue that actually doing a performing thoracostomy on an unconscious patient will cause them to go uncon. This will basically mean that you will have to do airway management as well. And there I want you to do that decision and decide, hey, is this patient, if he's obviously conscious, is he critical? Is he like so cyanotic that I have to do this immediately? Or do you think, hey, I have those 30 seconds to spare that I can do that IM lidocaine injection into the chest and just wait those 30 seconds so I don't have him uncon and I'll have other issues such as having him or basically putting in I-gel or having somebody actually look at the airway continuously, etc., etc. You have more benefits when your patient is awake, but keep in mind that there are side effects of lidocaine, especially with the heart rate going down, and if your patient is very unstable, that might actually not really kill him, but it could complicate your treatment. So yeah, I want you to start off with that chest seal, that lidocaine, 100 milligrams intramuscularly into the chest. Perform the thoracostomy. After that, you're going to get a small message. We're going to talk about that in a second. Then you're going to insert that chest tube and then drain either using AccuVac or the suction bag. On a quick side note, this isn't the main topic of today, but proper fluid resuscitation, meaning giving blood or plasma, calcium, TXA is key on treating hemothorax. Now, of course, having hardcore hemothorax enabled does complicate this. This will mean that he's going to require medevac or basically Zeus heal. So keep in mind, if you don't have that enabled, that proper fluid resuscitation and TXA are key on treating hemothorax. Furthermore, it's very important that coagulation fails during cardiac arrest. So if you want to ensure that that coagulation works, you will have to have somebody doing CPR on that patient, okay? So just a general thing that you have to keep in mind. Now, about that small feedback that you're getting when doing that incision, there's basically 5 messages you can get. The first one, saying lung is inflating normally, this means there's nothing going on. You didn't really have to perform this thoracostomy. There's no point to it, therefore you can close the incision again. Now on that second message, thoracostomy sweep, lung is not inflating, this means that your patient is not breathing. Might be due to, for example, a obstruction of the airway or cardiac arrest, basically them not breathing. This means that the lung is not inflating because he's basically not breathing. The third one, lung is collapsed. If you have the only lung collapsed without any additional comments on that, this means that your patient had a tension pneumothorax. This means that you can close that incision because that issue has been fixed already or by that thoracostomy. Just keep in mind to slap on a chest seal if you haven't done that already. Now the last two messages are more of your concern, especially in hemothorax. Lung is collapsed, large amount of blood. This means that he's in tension hemo, because basically what that collapsed lung says is that the pressure buildup from either air or blood has been so great that the lung actually itself collapsed. And this later on, for especially as I said in tension pneumo, causes that cardiac arrest. And that last message, bleeding in pleural space, very important. This means that you will have to give TXA definitely because he's actively bleeding in there. Then again, you can drain either using the AccuVac or the suction bag. Just a little additional info on that drainage timing or draining timing. I don't need you to do it every second. That's personally, I think it's unnecessary. What I recommend you to do is do it like every 30 seconds to 1 minute. And actually closing the incision isn't really high priority, especially if your patient is in cardiac arrest or unconscious. Therefore, I would either put that to the side, or if you actually want to do the decision to close that incision, I want you to drain once, wait 1 minute, drain again, just to make sure that there's no actual bleeding anymore, and then you can close the incision. This is just to ensure that there's no bleeding, right? If he still has bleeding, if you still haven't resolved it, that's going to be an issue for you. And closing that incision is going to complicate that. You're going to have to do all of this again, give that lidocaine, etc., etc. That's just going to be a waste of resources and time. So yeah, another thing, the chest tube dislocating or being unsealed, that's very important to keep in mind that you basically, if the patient is standing and or walking, there's a chance of the chest tube dislocating, which would basically cause a pneumothorax, and you will have to perform the reseal chest tube action so you can basically fix it. Alright, just a little bit more on additional information. When there's a new injury being inflicted, the chest seal actually falls off, so just keep that in the back of your mind when treating somebody you've already treated with thoracic injuries. And as I've sort of talked about shortly, the dependence on settings, very important to keep in mind what your server has on settings, whether it's hardcore, whether it's deterioration chances, whether or not it's even enabled. And then either change your equipment or your way of treatment appropriately. And then I just have a small little summary for you guys who did not really want to listen to this whole thing. Basically, what you can think of is if there's only uneven chest sides without anything else, it's either going to be pneumothorax or tension pneumothorax. Any form of tracheal deviation is going to be a tension pneumo. That extensive bruising, upper chest especially, or the lower and upper chest, is going to be that hemothorax or a tension hemothorax. And diminished breath sounds can either be pneumothorax or hemothorax, or basically their tension versions. Keep that in mind. That basically wraps it up.